This afternoon, what we'll do is review the protocol. We'll review it in two sections. The first part is we'll review the two core skills of HRT and function-based interventions. And then after that, we'll talk about how the actual treatment, CBIT, eight session treatment is structured. At that point, we'll practice. I'll do a case demonstration here, get a volunteer, do a case demonstration, and show you what HRT would look like, and show you, if we have, looks like we have time, I'll show you what function-based interventions would look like in terms of how the interview might go. But I'll probably focus primarily on the HRT component because that's probably might be the part you're least familiar with. And then if we have any time at the end, we'll do a little case discussion. So we're going to first start by reviewing HRT and function-based assessments. Start with HRT. Habit reversal has three primary components: awareness training, competing response training, and social support. Habit reversal is done one tick at a time. We treat one tick, usually one tick per session. Okay. And we do all three components: awareness training, competing response training, and social support for each tick in a session. Now, that's the way the manual is written. If you understand manualized interventions, if you understand therapy manuals and how psychotherapy in manualized format should work, you understand that it's not just reading a book and doing it. You understand the principles that the book is giving out. The book is a general guide. If you follow it, you'll generally get a specific result. However, the book has to be adapted to your patient's needs. The manual has to be adapted to your patient's needs within a certain range. So if your patient is having a hard time becoming aware of a tic, you may have to spend a little more time on that. Or maybe you can speed it up a little bit if they're getting it really quickly. You have to use your clinical judgment at that point. In any case, we'll talk about the three components here. Let's start by awareness training. So we identify the tic that we want to work on, and I'll talk about how we do that later through our tic hierarchy forms. But we start with the tic we want to work on, and then we have to understand that the purpose of awareness training is to help the client discriminate episodes of their behavior. The point is to get them to know when they're ticking. Now, everybody with Tourette's knows that they have tics. Well, not everybody, because sometimes there are adults who have tics that don't know they have tics, but generally, if a person has a diagnosis of Tourette's, they know they tic. But that's a very different thing from knowing when they tic. Okay? Knowing that you tic and knowing when you tic are very different things. People with Tourette's often don't know when they're ticking. And the point is to make them aware of when they're ticking. Now, when people hear this, they get a little nervous. They're like, oh, we've always been told not to bring attention to the tics. It'll make it worse. It'll make their tics flare up if they start to notice it a lot. Now, there's some truth to that. We know that talking about tics makes tics worse. We know that making people self-conscious about their tics makes tics worse. But awareness, self-awareness, and self-consciousness are two very different things. Self-consciousness about a behavior comes from a history of being punished for having that behavior. You become embarrassed that you have it because you've received a history of punishment or aversive consequences based on that behavior. When you have that kind of history, you'll develop self-consciousness about a behavior. Self-awareness is not associated with a level of punishment for a behavior. To make someone self-aware of a behavior, you simply note when a behavior occurs without any kind of emotional valence to that notice that the behavior is occurring. The purpose of habit reversal and awareness training is to make someone self-aware of their behavior, knowing when it happens, not making them feel bad about it or making them self-conscious about the behavior. We do awareness training through three techniques: response description, response detection, and early warning training. We don't know how aware a person has to be of their tics before they can be said to be fully aware. What we do is we shoot for about 80%. So they can tell us about 80% of the time when they're ticking with accuracy. The rationale, so if we have a child coming in and we're doing awareness training for the first time, we might say something like this. The next thing we're going to do today is teach you to know when you're doing your tic. We want to work on making you more aware of when your tic's happening, because the rest of the treatment depends on you knowing exactly when your tic is happening or about to happen. It's very important that we get this right. If you want to learn to manage something like your tics, you first have to know when it's occurring. We're going to do a number of exercises today so that by the time you leave, you're going to be aware of your tic. Now, we also, when we talk about behavior therapy for people with Tourette's, we make sure we set the expectations properly for the family. We say behavior therapy for Tourette's is not a cure. This is in no way a cure for your child's tics. This is a management strategy. That's what it is. And if you learn the management skills, you can live a very effective life and your tics can be relatively under control. It's not a cure. There is no cure for Tourette's. Medication is not a cure for Tourette's. It's simply a management strategy that involves pharmacology. Okay. I often use the analogy of like diabetes management. So, for example, diabetes is a biological illness. It's a biological disease that there is no cure for. You can't take a pill to cure your diabetes necessarily, depending on the type, I suppose. But you can't take a pill to cure it, but you can effectively manage it. And the way you effectively manage diabetes is through behavior modification. You learn to check your insulin, blood sugar levels, you learn to inject insulin, you learn to eat right, you learn to exercise, you learn how to live a different life with your condition. And if you learn those management skills, things turn out all right. And that's really what we're talking about here. So we're going to begin learning your management skills. And the first thing we need to do is know when the problem's happening. After we give the rationale, we start with the response description component. Response description involves having the patient define in great detail the tic. We have them pay attention to the muscular sensations. We have them pay attention to the urge. We have them pay attention to what their body's doing at the earliest parts of the tic. We want a very, 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 very painfully detailed description of what they're doing. Now, this is done in conjunction between the therapist and the patient. So when I've seen habit reversal be done poorly, it looks like this when we're doing response description. Okay, kid has a tic like this. And the therapist says, okay, we need to first make you aware of your tic, so we're going to define it. Can you tell me what your tic is? Give me a definition of your tic. And the kid says, I jerk my head. And the therapist says, that's right. That's a great definition of your tic. And that's it. Then they move on. That is a terrible version of response description. That is habit reversal gone bad, because that's not the purpose of it. The purpose isn't to just communicate about what your tic is that you're dealing with. The purpose is to get them to think about what this tic is, get them to really pay attention to it. So I might say, if I heard that, say something like, your head, you said the definition of this is that your head jerks. Which way does it jerk? Kid says, well, I've never thought about that before. It goes back. I say, does it go straight back? I don't know, says the kid. Well, why don't you do it slow and show me? Oh, I guess it goes to the right. Okay. What else does your tic do? I don't know. It just goes back. Well, no, it doesn't. Slow down. Watch it. I don't know. I close my eyes. That's right. You close your eyes when you do it. What else do you do? I don't know. Why don't you do it in the mirror and watch? So they do it in the mirror. Oh, my head drops a little bit before I start it. It goes down and then back up. That's right. What else does it do? I really don't know. Well, did you notice your shoulder goes up every time you do it? And the kid says, no, I didn't. I said, well, try it and see. Hey, you're right, it does go up. And so, we just keep working on it over and over and over again until it's just very, very detailed. And then I'll say, do you know it's coming? Do you know before the tic happens? Do you feel it? Yeah, I do. I do feel it. It's in my neck. Okay. So now you get a feeling. Your chin starts to drop a little bit. You close your eyes. It goes back and to the right while your shoulder goes up. That's your tic. And that's what good response description looks like. It's very, very detailed. Now, again, the point of this isn't to get an accurate definition. I mean, you want to go for accuracy, but the point isn't to get it right necessarily. The point is to get it to slow down in the kid's mind, to get them to attend to it, to get them to think about what they're doing. And you want to kind of activate that slowing down process. That's really what we're looking for. Once they have a good definition of the tic, once the description is in place, then we practice response detection. Now, if a child has a hard time catching his or her own tics, they're not very self-aware, at this point, I'll do a couple things. Sometimes I'll have them sit in front of a mirror and while they're talking to me, tell me when the tic happens as it occurs in front of a mirror. Sometimes I'll have them watch videotapes of themselves to point out tics as they happen in the videotapes. Sometimes I'll do their tic in front of them and have them point out to me when it happens, just so we can understand that their job is to catch when the tic happens. But let's assume there's a little level of self-awareness there. What we want to do at this point when we come to response detection is I say, okay, for the next 10 minutes, we're going to sit here, and every time you do the tic, whenever it happens, just raise your finger. That's all I want you to do. I don't want you to do anything else when the tic happens, just raise your finger. And if you catch it, I'll say, good job. If you miss it, I'll stop and I'll say, don't forget to raise your finger. You just had a tic, all right? And that's all we're going to do. Now, habit reversal gone bad looks like this when we get to response detection. Habit reversal gone bad looks like this. I'm sorry if I'm getting out of camera view. Okay, for the next 5 minutes, every time you tic, I want you to raise your finger. Every time you do your neck jerking tic, raise your finger. You okay? Does that make sense? Okay, let's go. Good. Good. Put your finger down until you do it. Good. Now, how comfortable is this for you?
Not very comfortable.
Not very comfortable. And for an 8-year-old, it's even less comfortable. Okay? That's habit reversal gone bad, which is you stare down the patient and you stare them into submission. And that just does not work. And it's bad behavior therapy for a couple reasons. One is if you do that, the tic won't really happen because the kid will get so frozen, the tics will just stop. That's the first thing. So you'll actually not get a good sample of behavior. The second problem is it won't generalize because think of what you're really trying to train this patient to do. Would you want your child to be in a treatment where the only thing they're focusing on all day is monitoring whether they're having a tic? They're not paying attention to you. They're not paying attention to the teacher. They're not talking to friends. They're not watching. All they're doing is, am I ticking? Am I ticking? Am I ticking? Am I ticking? That's where stuff goes wrong. You don't want to create that. But yet in therapy, if that's how you do habit reversal, that's exactly what you're doing. You're saying all of your attention should be on whether you're ticking or not. Absolutely not. What we want is something like this. Hey, for the next 10 minutes, tell me what you did for this weekend. Okay? And you better not talk about tics. But by the way, if you tic, raise your finger and let me know. All right? What'd you do this weekend?
I went to the beach.
Went to the beach. Oh, which beach did you go to?
Crandon Park.
Okay. And then we get them talking. With kids, I'm talking about sports, baseball, school, whatever, but it sure as hell isn't about tics. And every time they raise their finger and catch it while they're talking about other stuff, awesome. I break it, stop, good job. If they miss, I stop and say, don't forget your exercise. And what I'm trying to do is teaching them to do two things at once. I'm teaching them to engage in their life, which is what's really important, but a little part of their brain should be focusing on, am I having this tic? Now, we don't overwhelm them. We don't say, every time you do any tic. I'm just saying the one we're working on. We're not going to overload you. It's just this one tic. Is that happening? And while it's happening, just let me know. But we're going to keep talking about baseball because really baseball is the important thing, not this darn tic, that kind of thing. And so we keep practicing over and over and over again. And we go until the child can point out about 80% of the tics correctly. And once they can, then we go into the next phase. The next phase is early warning training. So we get them in early warning training to start thinking about the urge to tic and the earliest part of the tic movement. So we say something like this. Okay, you did an awesome job catching your own tics. Awesome. You did it great. But now I want you to do what you can to tell me when you're about to tic. When you get that feeling in the back of your neck that you talked about, tell me when that shows up. When your chin dropped, the earliest part of your tic movement, that tells you that the tic is coming. When your chin drops, tell me when that's happening. So I want you to, for the next 10 minutes while we talk about baseball, I want you to tell me when that feeling shows up in the back of your neck, and I want you to tell me when your chin drops a little bit. Can you do that? The kid says, okay. Now, it's a little more difficult because you, as the clinician, can't see when they have an urge. You don't get to see that. However, if you work with these kids long enough, you know when they have an urge to tic. You can see it come across their face. It's kind of like a tension that shows up when they have the urge to tic. when you're working with them in session. And that's when you can ask them, do you have the urge? And if they say yes, you say, don't forget to raise your finger. If they say no, then say, okay, just checking. And we go on and we have them practice telling us when they're about to do the movement and getting used to noticing those kinds of internal experiences. We try to shoot for about 80% correct if we can. It's kind of hard to measure. After we feel that they're fairly aware of their tics, at that point we start competing response training. Now, competing response training has the purpose of giving the patient a behavior to do that's physically incompatible with the tic. At least that's how we sell it. So we say, now that you're aware of the tic, we're going to teach you a way to stop the tic before it really gets going. Either going to prevent it from happening or we're going to kind of disrupt it. So we want you to do is we're going to have you do a behavior that physically prevents the tic from happening, or at least makes it harder to do, every time you feel the urge to tic or you've actually done a tic. All right? We're going to ask you any time of day when one of these when your either urge to tic happens or the tic itself shows up, we want you to do this exercise. And we want you to do this exercise for a minute or until the feeling goes away, whichever's longer. All right? When we do this, we use 3 techniques when we train competing responses. We have choosing the competing response, the therapist simulates the competing response, and then the patient practices the competing response in session. Let's talk about choosing the competing response. When we choose the competing response, we're trying to find something that the patient can do that's physically incompatible with the tics. That's at least how we sell it to the patient. There's some evidence that says that might not be necessary, but the way we describe it is that we're trying to get something that is, when you do this competing response, you either can't tic or it's much more difficult. It also has to be something that's less noticeable socially than the tic, and it has to be something that's less interfering in your day-to-day life than the tic. And it also has to be something that you can do for a minute or until the feeling goes away across multiple different situations. So, say, Billy, you're doing your neck jerking tic. What would be a good exercise? Remember, the exercise that we have to come up with has to meet 3 rules. It has to be incompatible with the tic. You can't do the tic and that at the same time. It has to be something that's not as noticeable as the tic. And it has to be something that you can hold for a minute or until the feeling goes away across a lot of different situations. And Billy says, I could do this. And I would say, that's a great idea. Let's look at it. Can you do this and do your neck jerking tic at the same time? And he says, nope. You're absolutely right. There's one of them. Can you hold this for a minute? And can you do it in almost every situation you're in? And he says, yep, I think so. Great. Billy, do you think anybody's going to notice that you're doing this? Oh, yeah, probably. So, but I will do just that. I won't automatically say no, because why? What I'm trying to teach this child and the parents who are in the room at the same time is I'm trying to teach them the rules. I want them to be able to think through everything that we're doing and the reasons for it, because ultimately my job as a behavior therapist is to make myself obsolete. I shouldn't be necessary when I'm done because they'll know the management principles. We should put ourselves out of business, and if we're not striving to that, then we're not doing the right thing, I think. So we teach them the rules, and we work through every competing response that we discuss in the context of these rules. Now, ultimately, I know exactly what I want them to do, and most of the time, 9 times out of 10, they'll get to exactly where I want them to be, but I don't want to start with me telling them what to do. I want them to come to that themselves. Here are some examples of competing responses. If you can read those, I don't know, but arm movements, so the kind of arm jerking things. We might have them put their upper arms or elbows into their side, hold it like that. That would be a common one. Putting hands like this. Eye blinks, which are really tough to treat, actually. Eye blinking, the competing response for eye blinking is shutting your eyes really tight. I'm actually kidding, because if you try walking and doing that, you'll be in trouble. And if you try driving, you'll be even more trouble. So we don't do that. No, our competing response for eye blinking is we fixate, and this is for eye rolling, eye darting, all the eye stuff. Fixate on a point about 3 to 4 feet in front of you, and then do a soft eye blink every 1 to 2 seconds, very controlled, like this. And do that for 1 to 2 minutes. That's a tough thing for kids to do, and just eye blink tics are tough in general to treat. All right? There really isn't a great competing response for eye blinks, eye rolling. Hand, wrist, hand movements, same kind of thing. Hands on the arm, hands like this, something like that. Head jerking, competing response is usually something like this. If you can't see what I'm doing, that's kind of the point. It's gently dropping the chin, tensing the neck muscles slightly. All right. Vocal tics, I think I have another slide here. Basically, any movement that you can have, you will have you have to come up with a competing response for. And basically any muscle group that you have can be a tic. I remember when we were doing the large CBIT studies, I was the supervisor for the whole group, so we'd weekly have a phone call for all the therapists around the country who would call in and do the phone supervision as a group. And every week it would start the same way. How's it going? How's everybody doing? How are your cases doing? And are there anybody need any help with anything in particular that we could all discuss? And every week there'd be, I have this kid who has this tic, I don't know what to do for a competing response. And the best one we had, and we'd all help each other out, like figure out what a competing response would be. And usually it was like, oh, my kid does this head thing, and somebody right away, oh, I had a kid like this, why don't you try this, it worked well for me, it would be that kind of stuff. We had one guy call in one time as a therapist, and he goes, okay, I got a new tic. The kid I'm dealing with has a butt clenching tic. I'm like, a butt clenching tic? And you could just hear silence, across 6 sites around the country. It's like, what do we do for butt clenching? Never thought about that. And you could it was like literally for about 3 minutes, just silence. You could hear shifting around, and you just knew throughout the country there were a bunch of psychologists like squeezing their butt, trying to figure out how to stop it. And actually what we came up with was something like, holding twisting your knees a little bit inside and in your inner thighs and tensing them right here and then right here. And then when you do that, you really can't clench your butt. It's obscene, isn't it? So you're kind of flexing and all that kind of stuff. But ultimately, you have to play with it. When you get a new one, you just have to kind of work through it and think about it. And it really helps if you can sort of put yourself in the client's position and try to emulate some of their tics. So you can feel what it would be like and practice the competing response with yourself before you actually ask your patient to do it. Vocal tics, all vocal tics, doesn't matter, stay out of content, it doesn't matter what they're saying, if it's a swearing tic or something like that, or the words are irrelevant. All vocal tics are treated the same way. They're all treated through a diaphragmatic breathing competing response. But it's important that the breathing pattern actually go opposite that of the of the tic itself. So for example, if the tic is made through an exhale through the mouth, the competing response should never include an exhale through the mouth, because that could trigger the tic. So if you say to your patient, every time you feel the urge to go, I want you to do this. Breathe in through the nose and out through the mouth for a minute. Well, what's going to happen? That's what's going to happen, because that is what happens. And so you always want to go out the opposite channel of the one that's involved in the tic. So if it's a competing response that involves breathing through the mouth, where the tic is made on an exhale through the mouth, you inhale through the mouth and exhale through the nose. It will prevent the tic from happening on the competing response breathing pattern. And again, you do that breathing pattern for a minute or until the feeling goes away. Once you've come up with your competing response, what we then want to do is have the therapist show the competing response to the patient. So we would say something like this. Okay, we've chosen your competing response for your neck jerking tic. Now here's what it should look like. Every time you feel the urge in the back of your neck, so let's say I'm sitting there watching TV and I feel this urge in the back of my neck, I should go like this. I should tighten my neck muscles. Now I'm still watching TV, that's really important. I don't want to miss anything, but I'm tensing my neck muscles and I'm just waiting. And then I kind of guess about when a minute's up and I ask myself, do I still have to do it? Do I still have the feeling? If the answer is no, then I can let go. If the answer is yes, then I just keep it going and then keep watching TV again. And every once in a while I'll check in. Is the urge there? If it's not there, then I can let go. That's it, all right? Another time I'd do it, let's say I'm sitting there and I notice my head start to go down. I would stop what I'm doing, I'd tense my neck muscles, and then I'd go back into what I'm doing. And at the end of the minute I'd ask, do I have to do it? If the answer is yes, keep going. If the answer is no, I stop. That's the second time you do it. The third time you do it, let's say you're actually sitting there and you're watching TV and it's a really good show and you notice yourself doing a couple, oh, wait a minute. Stop, tense your neck, keep it down, At the end of a minute, do I have to do it? If yes, keep going. If no, let it go. All right? Those are the 3 times you do it. And the child says, but if I've already done the tick, why would I want to do my exercise? If it's already out, so what? It's already done. Why would I want to do my exercise then? The answer to that is because when you look at the temporal distribution of ticks don't occur one at a time. They occur in clusters. Right? So if you really take, if you were to watch hours of ticks, what you would see is that they don't occur at random times. They occur in clusters. So when one tick happens, there's a much greater chance in the next few minutes a couple other ticks will happen. And that's true across the board. And if you look at those clusters actually occur in clusters. There seems to be some really interesting temporal fractionation going on here. And what our idea is if you can get in and stop the first one, like right after the first one you use your exercise, you might be able to disrupt that larger chain of ticks that occur right after. So that's why we still do it even after the tick occurs. At that point, we have the patient practice the competing response. And the patient practices the competing response much the same way we did awareness training. So I'll sit with the patient and I'll say, okay, for the next 10 minutes, we're going to talk about movies or whatever you want to talk about. And every time you feel the urge to do your tick or you feel, or the tick actually happens, we want you to do your exercise for a minute or until the feeling goes away, whichever's longer. It's up to you to remember. If you remember, great. I'll let you know you did a good job. If you miss it, if you forget, I'll remind you to do it. All right? So let's get started. So then we start talking about movies and the kid's going like this. And I'll say, oh, wait a minute. Don't forget your exercise. You're doing your tick. Okay? It's like, oh, okay. So we practice. And we just keep doing that over and over. It's a very discrete trial kind of skills training thing. And eventually the kid gets very good at doing this. And then we'll process, is the urge going down? What's happening? Does it go away after a minute? That kind of stuff. We'll have those discussions if we need to. But we train them very specifically how to do this in sort of a discrete trial way. Now, let's talk a little bit about the competing response, because this is a little shift into mechanism. It's a weird little thing. Some of the data out there suggests that the competing response doesn't have to actually physically compete with the tick. So essentially the rule is, when you feel like you have to tick, do something else but don't tick. All right? And keep doing that something else and not ticking until the feeling goes away. It doesn't really matter what it is. Okay? Now, why do we say that it has to be physically incompatible? The reason we say that is it sounds insane if we don't, essentially. Because what it sounds like is, don't tick, which is essentially what we're saying. We're kind of saying don't tick. We're saying do something else instead. And that doesn't go over really well with patients. It's like, oh, really, just not tick? I think I'd have thought of that. But we have to sell it in a different way. And now, why might that actually work? Well, essentially, if the rule is do something else but don't tick, you're allowing habituation to the urge to take place, right? And compatible, incompatible, competing response, it really doesn't matter. Habituation doesn't care whether it's compatible or incompatible. It just needs time. It needs time for the habituation to take place, however you get there. The other thing is it might be that what happens is, there could be the habituation model, but it could also be, remember, that you could be sort of flooding the basal ganglia with other motor signals. And if that's true, it also doesn't matter if it's compatible or incompatible. It's just simply doing more movement helps you decrease the tics. And that could be something else that's happening. So it actually kind of makes sense, but it just doesn't make sense to a patient right away, so we don't sell it that way. What this tells us is that if you can't come up with a good competing response that does seem right and appropriate and incompatible with the actual tic, you can try other things as well. That's really what this is telling us. We do know, however, the data are pretty clear that the competing response has to be done contingent on the warning sign or the urge to tic or the tic itself. If you try to do it in a non-contingent fashion, it won't work. So here's what I mean. I've had people come up to me when I've done talks, and they've come up to me and said, I got to tell you, I've tried this habit reversal stuff, and it really just doesn't work. I've not had any luck with it. I'm like, okay, well, why don't you tell me what you're doing? And they say, well, for example, this last patient I had, it was like a 15-year-old boy who, we did the competing response, we tried to do it, and he came back the next week, and he just said it was too big of a pain for him. And he found it too disruptive for him to do that competing response every time he did the tick because he had so many ticks. And so, we agreed that a better strategy for him would be if he would carry a card with him throughout the day, a self-monitoring card, and make a mark every time he did a tick. Okay? And then at the end of the day, he could do 1 minute of competing response for every mark he had on his card. So if he had like 20 marks on his card by the end of the day, he could do 20 minutes of competing responses before he went to bed. And it didn't work, so I really don't believe much about this treatment. Now, I'm looking at this thinking, seriously? Really? I know you can deviate from a manual a little bit, but that's a pretty far deviation. That kind of protocol doesn't work. The competing response is important. It has to be done contingent on the behavior itself or the urge to do the behavior. If it's not, it won't be effective. Now, the competing response is held for a minute or until the premonitory urge goes away, whichever is longer. Why is that rule there? Well, we talked about the urge going away, that habituation hypothesis. So that's why that function is there. The minute is there for a different reason. When Azrin and Nunn originally proposed habit reversal in '73, they proposed a 3-minute competing response. So every time you feel the urge to tick, do 3 minutes of competing response. 3 minutes of competing response for me at age 39 feels like an eternity. 3 minutes to an 8-year-old is an eternity. I mean, there's a big difference. They can't do competing responses for 3 minutes. So the question is, can you make it any shorter and still maintain efficacy? We did a little study a few years ago where we compared 5-second competing responses, which are like virtually nothing, to 1-minute competing responses to 3-minute competing responses, this sort of parametric comparison. And what we found was that all 3 durations, 5-second, 1-minute, 3-minute, produced equivalent decreases in ticks in the short term. So it didn't really matter. If you did anything contingent on the tick, you saw a decrease in ticks immediately. Or actually, it wasn't ticks. Ticks weren't our target. It was something else. But essentially, with habit reversal, you saw a decrease in the target behavior immediately. The problem came when we did a follow-up a month later. What happened a month after treatment ended? Well, a month after treatment ended, the people who had gotten a 5-second competing response completely relapsed. They lost any treatment gains they had. The people who had a 1-minute or 3-minute maintained treatment gains they had, and the 1-minute was way more acceptable than the 3-minute competing response to the patient. So that's actually where we derive that 1-minute rule. It's 1 minute or until the urge goes away, whichever's longer. Now, another concern people have is that we get this question from parents. So aren't you really just teaching them a new tick? So now aren't they just going to be doing this the whole time, the competing response? And the answer is no. That doesn't seem to happen. What really seems to happen is that the competing response just fades away as the urge to tick fades away. So they just start to feel the need to tick less and they don't do the competing response anymore. It doesn't become a new habit. Now, why is that? I think it's because we're not teaching a functional replacement for the tick. In other words, that urge, or that competing response is not taking away the urge. When you start doing the competing response, the urge many times will go up, it won't go down. So the competing response is just holding the behavior until the urge can fade away. So it's not taking away the urge like the tick did. Now, and for that reason, I don't think it becomes a new behavior, a new tick. There are strategies that people use where they try to do, and people with Tourette's do this, where they try to move the tick around. So instead of going out like this, they might go like this. Functionally, that serves the same purpose. It too gets rid of that urge. It too gets rid of that feeling. And in that case, I think you're more likely to keep this being a new tick now. When people do bad habit reversal, again, and I've heard this a ton of times, people say, oh, well, let's give you something else to do to get rid of that feeling, and that can be your competing response. No. If your competing response takes away your urge for you, it's not a good competing response. You're creating a new tick at that point. So you have remember the purpose of the competing response is to allow habituation, not to remove the urge. So think about that. The last component of habit reversal is what we call social support. Social support, the purpose of it is to reinforce and prompt the use of the competing response. We find a significant other, Usually in a child's life, it's their parent, but it could be an older sibling or something like that. And sometimes a teacher. I don't like to bring in teachers right away. I want the families to be very comfortable with this before it ever enters the school. And even then, I'm a little leery because teachers can really go bad on this if it's not done well. I want to have the parents are to do two things. If they see the child doing the tick that we're working on, but not using the competing response that they've been trained to do, then I want the parent to simply prompt the child to use the exercise. Notice I said prompt, not force, not badger, not cajole, not bribe, prompt. All right? And prompt is simply, don't forget your exercises. That's it. You can quickly get into a battle that's probably not worth it if you go any more than that. And the parents will come back and say, well, he doesn't want to do it. I prompt him and he doesn't do it. It's not your worry. Your job is to simply remind him it's there. We can do other things to help him comply. Your job is not that right now. Don't get into the battle. Simply prompt. Assume he doesn't know, remind him that it's happening, and then prompt him. Okay. We also want to have the parent praise the child if they see the child doing the competing response correctly. So if the parent comes into the television room, the kid goes like this, and the parent sees the child do it, then we'll say, hey, your job, Mom, is to say, awesome, you did a good job. Way to go. Good job using your exercises. Now, we don't know how much social support is necessary in CBIT. There's a study in adults for a condition that's not Tourette's that shows for adults, social support doesn't add anything to the efficacy of habit reversal. For kids, I just actually read a study that suggested that it does add something for children, which kind of makes a lot of sense. So right now, we always recommend that habit reversal include social support, especially when dealing with children. When we do this, obviously we identify the support person, have them come into session. Again, when we do treatment, I honestly, it's probably, I don't know, maybe I'm overstepping, but it's probably very similar in what you would do for ADHD. In terms of it's really more of a coaching model. I don't feel like I'm doing therapy a lot of times. I feel like I'm doing coaching in a lot of ways when I do this. In fact, I feel more comfortable around OTs and PTs than I do psychologists a lot of times because they come from more of a let's get it this sort of model. There's not a lot of exploration and all that kind of stuff. And so this is a very technical kind of approach, which can be irritating to some psychologists. They want to get into the meat, and there isn't any meat. Just do this, and we'll be okay. And so we want to find a person, bring them into session. The parents and the kid and I are sitting in session. We're working together. Now, when it comes to training the patient or the parent how to remind the client, you might think, really, you have to train the parent to do this? Well, you guys won't. You know the importance of parents doing something right. But think about how we have to train this. What are the families who are coming in, what are their experiences before they come to session, with their child with Tourette's? Well, here's usually how it starts. Stop it. Something wrong with your eyes? Let's go to the eye doctor. Let's get you checked out. Oh, he's got a cold again. 6 months later. We better bring him to the allergist. I think he's got allergies. Stop it. You're irritating me. And it gets worse and worse and worse and worse. There's a lot of focus on the tics. And it's by the time a kid actually gets diagnosed, it's usually consumed a couple of years of the family. And they're trying to they finally figure out what it is. And there can be, a lot of times, a lot of built up social dysfunction that happens because of this. The parents interact with the kid in the ways that they normally wouldn't have. And the kids interact with the parents in ways that they normally wouldn't have. The parents have become the tick police in situations where it hasn't gone so well, where their sole job in life is to check and see how often these tics are happening and getting the kid to stop. I mean, all that stuff builds up. And then they come to you. And if you just tell that kind of person, if you just tell somebody in that family situation, hey, when your child does the tics, remind them to use your exercises. It won't look anything like you hoped it would. It'll look more like, you're ticking again, stop it. That's how it'll look. You're not listening to the doctor, stop it. It won't look like you wanted it to look. The way you wanted it to look as social support was, hey, Billy, don't forget your exercise. That's it. If a person has a history that you don't deal with, it's going to look a lot worse than that. So I'll sit down with a parent and I'll say, okay, your job is to do one thing, is to remind your child to do their exercises when they tick, but they forget to use their exercises, all right? I want you to say this, and only this, when your child has a tick that they don't follow by an exercise. John, don't forget your exercise. In that tone, not John, not that, not John, not that. John, don't forget your exercise. That's it. Can we practice? And the parents look at me like, oh my God, this guy's crazy. And the kids are like, I love it. And so we practice. John, do your tick and don't forget, and don't do your exercise. And John doesn't do his exercise. His mom says, John, you're ticking again. Don't forget your exercise. No, not right. Do it over, Mom. What did we do wrong there? I reminded him. I wasn't kind of sarcastic about anything. No, but you said the word tick. We don't say the word tick. All you need to do is say, don't forget your exercise. Okay, and we'll practice that until the parents get it. And I explain why. I'm like, you have to understand what your child controls and what they don't control. They don't control whether they have tics. That's the neurological part of their problem. That's the part that's uncontrollable. But they do have control over whether they use their exercise. So it's fair game for you to expect that they use their exercise. It's not fair game for you to hammer on them for having their neurological symptoms. Because what you're doing now, if you're hammering on them for having tics, that's the same as hammering on a diabetic child for having bad insulin levels. You don't do that. That's the same as telling the kid in the wheelchair because he's paraplegic to get up and walk because you're sick of pushing him around. That doesn't work. But what you can do is expect that he can control what he can control. And we really send that message, and parents don't like to hear that always, and I don't pull that stuff out unless it's really kind of like there's a problem in the family. But that's kind of where we start. And then we also train the parent to praise the client for using the competing response correctly. So what would that sound like? Again, we go through a lot of detail in having the parent practice in front of us because we don't want the parent to praise the child for not having tics. That sounds weird, but we don't. We want the parent to praise the child for using the exercises correctly. So the parent might say, hey, John, you just did a good job stopping your tics. No, we don't say that. You said tics. Okay? John, you did a good job using your exercises. Nice. Okay? There's a distinction. You got to catch that distinction. And it's really important because one of the things we start to see is parents will start to kind of go overboard on this when they think that they're doing the rewarding. And I've heard parents say, this reward stuff, it doesn't work. Well, what do? Hey, I told him like last week, if he could go a whole week without having a tic, I'd buy him a car. And you know what? He didn't last more than an hour. It's like, oh, that was nice. You set him up to fail on that one because that wasn't going to happen. And we don't reward tic reduction. We reward effective management. I bet if you told him, if you go a week using your competing response every time you do the tic, or at least following through when I remind you, I bet you'd be buying him a car in a week. Because that's the stuff he can control. He can't control whether the tic pops out or the urge to tic pops out. And that's an important distinction to remember for parents. We do use motivational strategies to enhance compliance. We do have a reward system that we use. And again, it's done just for that. It's done to enhance compliance. It's not done to reduce tics. Now, enhancing compliance will probably bring about a tic reduction. We sure hope so. But what we're trying to do in a reward system is to enhance compliance, not reduce tics. And all the things we reward, practicing your strategies when we ask you to practice, listening to mom or dad when they prompt you to use your exercises, all those kinds of things, those are rewardable kind of events. Those are behaviors you can reward, and we build that into our strategy. We also do something called an inconvenience review, where we weekly talk about all the problems that tics have caused the child in the past week. And every week we review all of the hassles that the tics have caused and see whether they're going up or down. And what we hope to see is that as treatment progresses, we see a decrease in the problems that tics cause week to week. We'll talk about how we do that in a little bit. Okay. Any questions about the habit reversal piece now? Then we'll go into the function-based work. Yeah. Oh.
Do all the sessions involve both parents and kids there for the whole 8 sessions?
Usually. As the kids get older, we usually see less of the parents. I always have the parents there for the first session of habit reversal, always, throughout the whole thing. As the kids get older, I usually have the parents out a little bit more, and then always bring them in at the end to talk about what we did and so on and so forth.
And older means
14, 15, 16, 17.
teenagers.
Yeah. Yeah.
As you work through the first tick, you know, with the habit reversal with your client, are they able to do the habit reversal process themselves with their future ticks?
Yeah, exactly, and that's the whole point. What I do in session 1, like what you'll see me demonstrate up here today, will look very different from what session 8 would look like. Session 8 would look like this. Literally, you could do habit reversal in 30 seconds with a tick. So you've got your arm jerking tick. What do you think your exercise should be? I should put my arm in at my side. Why? Because I can't do my tick, I can do it anywhere, and I can hold it for a minute or until the feeling goes away, whichever is longer. Okay, when do you do it? When I feel the urge that's in my shoulder or when I actually do the tick? Okay, great. How long do you hold it? Minute or until the feeling goes away, whichever is longer. When do you do it? Every time I feel the urge or I do the tick. Okay, good, let's go. And that's it. You know, I mean, and that's the point you want to get to. Or, you know, what you ultimately want to get to is, okay, you don't have this tick, but let's assume you had this tick. What would you do? And the kid can tell you right away. That's where you want to build them to. And we do leave them with that. We leave them with the idea that, look, you ultimately will have ticks in the future. You know, if your ticks don't go away like some do, but if you're the one of the third who really sticks around, you're going to have new ticks that show up. That's the nature of the disorder. What you're learning here is how to cope with the new things that do show up and the ones you currently have. So what can we do? Let's practice some things that might not happen or might not have happened to you yet. So that's what we're building toward. Other questions? Yeah.
It seems completely contingent or dependent on the child being able to identify the urge. Is that ever a problem?
It's better if they have the urge, but it's not required. Okay, I mean, ideally, what we want is the child has the urge and they do it contingent on the urge. That's when you'll get your best result. But you don't have to have an urge for this to be effective. If you do it even after the tick itself happens, you can get a general reduction in tick frequency. Now, it may not be as robust, but you'll still get a pretty good reduction. I think it's because of those bouts things. You know, so if you can disrupt after the first bout, just generally your frequency will drop. Go ahead.
Practicing the competing response even if they can't identify the urge.
Contingent on the tick, or the earliest parts of the tick starting.
What portion of young children have you found, like, 8 to 10-year-olds, have you found can identify the urge?
Initially, if I just asked, do you have an urge to tick? Maybe you'll get 50 or 60%. But if you say, can you tell when you're about to tick? Uh-huh.
You do all that.
Yeah. I mean, if you do that, if you ask it in different ways, you'll get most of them can tell.
Thanks.
You know. Yeah.
Can you give a few examples of strategies you might use to increase compliance within kids and then to help parents help kids increase their compliance?
Sure. So one of the first things we do is up front. I'm very clear with them. I mean, you know, everything psychotherapy literature tells you is you really build expectations. You really, get a lot. I don't do that. I say, it only works for 53% of the people. You need to work your butt off to respond. If you do, you'll do pretty well, but you got to work hard. If you don't want to put in the time, if you don't want to put in the effort, it's probably not worth it. Okay. So clinically, I mean, we didn't do that in the trial, but I mean, clinically, that's what I do. And I'm very upfront. This is a ton of work, mom, dad, kid. If you're not committed, don't do it. Otherwise, you're just setting yourself up to fail and spend time and money. So I do a lot of stuff on the front end. So a lot of times, people come in kind of motivated to begin with. The other thing we do is we start with a tick that really bothers the child the most. So like in OCD, you start kind of in the middle. And then you work up a hierarchy of anxiety-provoking stimuli. We start with the worst thing, the thing that bothers this kid more than anything else. And we say, this is the only thing we're working on. And we're going to get this taken care of. And we bring that down. And usually that gets enough buy-in for the kid. They're like, oh, wow, this really works. It's been a week and this is almost gone. And then they have a little more compliance and motivation to do it. Those are probably two of the biggest things that we do to just generally structurally enhance compliance. If we have a child who is just struggling a lot with compliance, that's when we break in the more the reinforcement programs, and we give them, if you do X number of competing responses unprompted, your mom catches you, we'll have times when she's watching, then you'll get points. Points can be exchanged for, it's your typical token economy kind of thing. For every time you catch it outside of those times, you get even more points, those kinds of things. If you do the competing response when your mom prompts you and you don't complain or whine, you get X number of points. And so, we'll set up those kinds of things, targeting what the parents are saying the compliance problem is. So those are typically what we do. All right, any other questions? Yeah.
What if a tic starts when a child has to start writing? For example, my son, whenever he has to write something, the first thing he'll have lots of tics.
Mm-hmm.
Then with time, they turn down. But in the beginning, the first time, he will just bullets for like 2 minutes.
Okay, so what I would do for that is I would probably do something like have him, I'd have to play with a little bit just to see where the tics started to happen. But what I'd probably do is have him hold his pen right on his paper if he had the urge to bang it, and then I'd have him tense his arm right there without writing at that point, but just have him tense his arm and just wait for that feeling to go away, that banging feeling. Because if you're tensing your arm, you can't really, without untensing it, you can't lift it up. So have him tense his arm and hold it there and wait till that feeling goes away, and then proceed to write. That's probably how I'd start, unless there was something else I could think of when I met with him. So that's probably what I would do. Other questions? Yeah.
When you're doing your competing responses, do you often encourage the parents to share with teachers or other adults in their life what the competing response is? So if it's okay to use that example, I could see a teacher saying, you're not getting to work, you're not starting.
Oh, absolutely.
So you would share that this is his competing strategy. Okay.
Absolutely. And I might even start by saying, at first, don't do this at school. Let's just practice at home and get good at it at home, and then we'll talk to the teachers. And that's why I say I get a little leery about bringing the teachers in right away. But if we did bring it to school right away, I'd probably bring the teacher and say, look, I don't want you to do anything. I just want you to be aware that this is happening and not to hound him about it when it does. So.